Good morning and good afternoon, everyone, and welcome to the December edition of the Johns Hopkins Informatics Grand Rounds session. My name is Nick Dobbins. I'm an assistant professor here in biomedical informatics, and it is my distinct pleasure to welcome Dr. Sarvesh Soni to join us today and present his work, which I think is really exciting and hopefully interesting to everyone here on the Grand Rounds. So Dr. Soni is a research fellow at the National Library of Medicine. He's an expert in natural language processing, or NLP, and has published a lot of really interesting papers and work that I've followed for many years on various topics such as question answering systems, using electronic health record data, deep learning systems for information retrieval, paraphrase generation, FHIR, and logical forms for question answering. So all sorts of really interesting topics. Dr. Soni has a Bachelor's of Technology from Maulana Azad National Institute of Technology, a Master's in Computer Science from the University of Florida, and did his PhD in Biomedical Informatics at the University of Texas. So please join me in welcoming Dr. Soni. And Sarvesh, please feel free to share your screen and take it away.
Thank you, Nick, for the introduction, and thank you so much for inviting me. It's a great pleasure for me to speak. I'm really excited to speak to all of you as part of the BITS Grand Rounds at Johns Hopkins Medicine, and I have no disclosures. And these are the objectives after attending this activity. If I could briefly explain it, at the end of this activity, you should be able to explain the significance of the task of automatically generating clinical progress notes. You can compare and contrast frameworks for automatically generating these notes, and we will also look at some strategies for for evaluating the automatically generated notes. Uh, so the focus of today's talk is going to be on automatically generating clinical progress notes. And the overarching goal of doing this is to relieve clinician burden. I have the disclaimer that the views are of authors and not of the government. And I think Nick already introduced me well, but this is just a very brief introduction about me. I did my bachelor's and master's in computer science, and my PhD is in biomedical informatics. My dissertation focused on question answering from electronic health records. And as a research fellow at the National Library of Medicine, my work has been focused on two broader areas, one of which is progress note generation, and other is question answering from electronic health records. The work that I'm going to talk about today is focused on the progress note generation methods that we developed over the past year or so. So let's begin with understanding what are progress notes. So progress notes are also called as SOAP notes. For some of you, if you remember it by that name, these are written regularly by clinicians to document the care that is provided to their patients. It contains important context that is used to share care provided to the patients by different providers. Ultimately, these notes reside in the electronic health records for record keeping purposes. The acronym SOAP comes from the four broader sections that are present in progress notes. So S stands for subjective, and this subjective section contains patient-reported information such as their chief complaint or their explanation of the symptoms of their own symptoms. And objective section contains the objective measurements on the patient, such as their vital signs and their lab values. Then there are two other sections which are called as assessment and plan sections. And these include important information about the diagnosis that clinicians give to the patients and their treatment plan for the patient. Furthermore, the assessment and plan section is divided in by problems. So what you see on the right-hand side is an example of two progress notes written one day apart. Like I mentioned, they are written regularly, so more often they are written on a daily basis. And these two progress notes that you see account for the progress that the patient made in terms of various treatments that are given to the patient. And the assessment and plan section, as you can see, is separated by different problems. So take an example of sepsis. So for the problem of sepsis, the first note mentions that the patient showed response to some treatment that was given to patient, and then that the plan was to continue antibiotics. And the next day, patient showed improvement to the treatment that was provided, and the patient was able to be weaned off of pressors, and the plan was to continue antibiotics. This is a very brief uh, introduction to what the assessment and plan section looks like in a progress note. There's huge amount of patient information available in electronic health records, and this huge information helps clinicians in gathering better assessments on the patients as well as write better progress notes. However, this information also leads to problems such as information overload and increased clinician burden. So, with this work, what we propose is to use this available data in the electronic health records to automate the process of progress note generation. So, the basically the natural language processing task that we are tackling as part of this work is to automatically generate the progress note for the next day given the progress note from the previous day and all available structured patient chart data that was recorded since the last note was written. So for visualizing the two notes that you saw on the previous slides are present here. And if we could utilize the structured data that's available in electronic health record to directly go from prior note to the next note. And the structured chart data that we are interested in are information that's available in the tabular format, such as the central venous pressure and heart rhythm. Coming back to the acronym for progress notes, which is SOAP, and the four major sections of progress note, the subjective section of these notes usually consists of patient-reported information, and they are better extracted from the conversation that clinician and patients have. And there's a large body of work that corresponds to automatically generating this section. The objective section is mostly copied directly from the charts and it doesn't require complex reasoning or complex human involvement in it. Interestingly, the assessment and plan section requires a careful analysis of the available notes as well as the available structured chart data. And as part of this work, we focus on automatically generating this assessment and plan section. So far, there's no existing large data set that can be utilized to build and evaluate methods for the task of progress note generation. So we went ahead and curated a data set that we like to call as chart PNG. We created this data set based on the publicly available data set called Mimic3. Mimic3 dataset consists of several categories of clinical notes as well as structured data on patients that were admitted to an ICU or intensive care unit. The dataset that we curated is on over 1,600 patients, and it consists of over 7,000 annotation instances. So each annotation instance consists of a prior note and a next note, and all the structured chart data that was collected between these two notes were written. So if you want to visualize from the previous slide, you have these two notes, the prior note and the next note, and then all the available structured chart data that was collected in between. So we have more than 7,000 such instances. And the amount of structured chart data that is present between any pair is more than 1,400 rows of data. I want to highlight that this is close to 1,500 rows of structured data that needs to be analyzed if you want to go from previous progress node to next progress node. And the reason I highlighted this is I will talk about in the next slide, where we propose the framework to automatically generate these progress nodes. Since the scale of structured chart data is too large, the current models that we plan to use, which were locally run models, or they're also called as open source models, they do not most often support the large input context. So we resorted to summarizing this data, and we take the task of summarizing this data by guiding it through the chief complaints that are automatically extracted from the assessment and plan section of the progress notes. The summarization step itself happens in two stages. So we first create an initial summary by using the first few rows of the structured chart data. And then with every subsequent chunks of rows, we refine that summary and ultimately produce the final summary. This final summary is then used alongside the prior node in order to generate the next node. We conducted a series of baseline experiments to see how the existing set of models perform on the data set and where they stand. And let's look at these few values to understand what we found. First of all, let's look at the metrics that we used. So the first one is the Rouge metric. Rouge metric calculates text overlap between the predicted progress node and the ground truth progress node, which is written by clinician and actually available in the electronic health records. So it is looking at directly available text phrases in the predicted progress nodes and comparing it to the actual progress nodes. The next metric is BERT score. The Rouge metric is focused only on text, so it does not really take care of the synonyms as much. So BERT score, on the other hand, takes care of the semantic similarity, where if you have two words that means very similar things and then they are present in both your prediction and ground truth, they are given higher score by BERT score. And the third metric that we use is called as METCOM. It works a little bit differently, as in it first extracts clinical concepts from the predicted progress nodes, and it also extracts clinical concepts from the ground truth nodes, and then calculates an F1 score between these two sets of medical concepts. The four baselines that you see in this on this table corresponds to the first one is prior node. So what happens if you just pass the prior progress node as it is without making any modifications? So that's a good enough baseline. And that the other three baselines are large language models. The first one is BioMistral, which is a further pre-trained version of the open domain Mistral model on PubMed Central Open Access dataset. The next model is called Mixtral, which is a mixture of experts model based again on the Mistral model. And we also use Llama 2 70 billion, which is the second generation of the Llama models provided by Meta. You see that we got the highest scores with the prior node baseline. And this is not because the prior node baseline is the best, but it is an artifact of how the nodes are written in the real world and the higher textual and semantic similarity between the prior note and the actual next note. And it's mainly an artifact of how the notes are written, where previous day's progress note is taken as a draft and they are edited for writing the next day's progress note, thereby corresponding to higher textual and semantic similarity and more number of common clinical concepts. On the other hand, the large language models generate these notes from scratch, so they do not exhibit uh, a lot of these overlaps, and thereby you see somewhat lower numbers in terms of these automated metrics. Among the large language models, we found that the BioMistral model achieved the best scores among the three, and we attribute this to the additional biomedical training that might have gone into building this BioMistral 7 billion model. To get a better sense of how the models generated actual progress notes, we also conducted a manual analysis of their predicted progress notes. So I don't want to focus on all the rows, but these two rows form our manual analysis. And these two rows highlight one of the main findings from this was that the first row corresponds to the proportion of predicted notes that accurately captured the relevant change information about the patient since the last progress note was written. So basically, it accounted for some relevant information that happened since the last progress note was written in the next predicted progress note. And the second row here highlights the proportion of these proportion of notes that accurately captured this relevant information if it was available to the model as part of the generated summary. So we saw that the model was more likely to use the actual information if it was provided to the model in the generated summary. So the generated summary actually played a really critical role in generating the automatically generating the notes. So this concludes this first part of the presentation where we proposed the task of automatically generating the notes. We curated the dataset called as chart PNG, and we highlighted some of the challenges that are involved in progress note generation. This work was also presented at AMIA in November. And before I go further, I want to quickly check if there are any questions for this part of the presentation before we move further in the second part.
Sarvesh, I see we do have one question in the Q&A from Ariana. I'm happy to read it, but
Sure.
does it sound okay? So Ariana asks, do the automatically generated progress notes take into account other types of preceding notes, such as long op reports and consult notes, or even nursing progress and pharmacy progress notes? Or are they strictly being developed based on the physician progress notes and the structured data in the EHR?
Okay, yeah, so that's one of the limitations of this approach, where we only accounted for the structured data and not the other nodes. The main reasons were mainly technical, where it was a challenge to even accommodate the structured data. So we did not at first thought to incorporate other types of datasets, which is part of the future work, where we can for sure incorporate other types of data such as radiology reports. So radiology reports contain very critical information for writing these progress notes sometimes. And so that's part of future work. For this particular task, we only take into account the last progress note and the structured data, if that answers. Yeah. Any other question? Or we are set to move forward. All right. Yeah. All right. Let's move forward. So we saw that this automatically generated summary was very important in generating better progress notes. So we explored this a little bit more. And so far, we have been looking at the locally run models, or they are also called as open source models, but we'd like to technically call as locally run models because you can run it locally, and somewhat that like how they are trained, and you have some source code available on those models. So the two models that we explored so far were the models that we explored so far came from these two open domain models, were like Mistral from Mistral AI and the Llama models from Meta. And there are advantages to running these locally run models, as like you can run these models entirely on premise. They can be transparent. You can adapt them to your use case because you can run the entire model yourself, and uh, you can be responsible for its security. You know what data is stored where, and so on. So it usually it accurately fits the use cases in the medical domain where these things are of paramount importance. However, these models also suffer from their own limitations, one of which is their limited input context size, and that also corresponds to somewhat limited reasoning capabilities of these models. And we are comparing these to these other range of models, which we like to call as the web-based models. So the ChatGPT model from OpenAI and the Claude model from Anthropic. And so both of these types of models, they are available usually via web APIs and exclusively through web APIs. So you cannot really download these models on your local server. So you have to send your data onto some of the online servers. And these models have uh, exhibited stronger reasoning capabilities as compared to the models that you can run locally. However, there's a caveat that you have to send your data outside of your own environment. So, as part of this subsequent work, we proposed to uh, we explored a method to take the benefits of both worlds, and in such a way that we don't have to send sensitive information to the web-based model. So how can we take the benefits of the locally run models while still utilizing these stronger reasoning capabilities provided by the web-based model? And using this, we proposed a framework that uses both of these models together. And basically, briefly speaking, the web-based models are used to filter down the huge amounts of structured chart data rows into smaller clinically relevant ones. And we aim to do this without sending specific patient information to their online servers. And ultimately, we use the locally run model for generating the actual progress note. So we don't really send the note text to the online servers. And how we do this is provided here as part of our proposed framework. Let's try to understand this and go through it one by one so that we have a better idea of how we approach this problem. So the first preparation step involved first extracting all the available problems that are present in the prior node. So the prior node, as I mentioned, the assessment and plan section is usually sectioned into different problems. So you have the problem of anemia and renal failure. So we automatically parse out these different problems and their associated contents. So for anemia, you have these content from progress note, and for renal failure you have its own content. Then we also extract all unique labels from the structured chart data of the patient. So you have all these different values, all these different labels and their values collected at different times. But what are the unique labels that we have on the patient? So that's what we prepare. beforehand. And then when we move on to actually prompting the web-based model, we do that by only passing the problem name of the patient. So take an example of anemia. So if for the problem of anemia, we only pass the problem name as anemia to this web-based model, and we pass all these unique labels for the patient without their specific values or time to the web-based model. And we prompt the model to uh, to distill these large number of labels into a few clinically relevant labels. So you may expect a filtered list of labels from the model for the problem of anemia, such as the hematocrit, hemoglobin, activity tolerance, and so on. But the problem is you can still have many rows for these filtered list of labels because these may be like the more common data elements that were collected for this patient during their stay. So what we did next was we applied a set of heuristic rules to further summarize this information. So a, a, a simple example to this is that instead of sending different uh, eight same measurements of the same label, for example, telling that activity tolerance was reported 8 times with these values at 8 different times, we summarize it in such a way that this activity tolerance for the label activity tolerance, the same measurement was reported 8 times from the starting time of this to the ending time of this, and the measurement was that the patient tolerated it well, right? So this helps us in going from all these numerous rows to getting to a simple sentence that summarizes that information. Next, we use this summary alongside the node snippets that you have for these particular problems. So for the problem of anemia, uh, you have these node snippets. You have this associated note from the past note, which is like progressive concern for GI bleed and so on. And you pass this summarized information that we curated using the web-based model. And ultimately, we prompt the locally run model to produce the to produce the final predicted next node for the particular problem. So in this way, we get the predicted next node for the problem of anemia. And we repeat this for all the problems that we find in the prior node. So for example, we run this once for anemia, we run this again for renal failure and for chest pain and so on. And then you get all these different progress notes, progress note text generated for these different problems. And we combine those in a post hoc manner, and it generates your final predicted next node. We use the same set of quantitative metrics and the same set of models, but I want to focus on these ablation results where we used the framework from previous step as well as um, incorporating like using the same framework but with incorporating this additional knowledge from the web-based model. And these for your reference, these metrics mean the same things. So Rouge is calculating the text overlap, BERT score for semantic similarity, and METCON for medical concept overlap. Then we found that all the large language models improved their performance on in terms of the METCON score. And we found that all the larger models improved their performance across all the metrics. So in terms of, and we saw improvements more than 4 points on root score and Metcon score for the Mixtel model, Mixtel 56 billion model, and the improvements were were large enough to also see the differences in our manual analysis that we conducted later on. In terms of the manual analysis, I want to focus on these two rows, which corresponds to one of which is from the same sets of manual analysis that we conducted in the last study. The first row here shows the proportion of model predictions that accurately captured the relevant information in the interim. And we provide some specific examples here where the goal note contained for the problem of tachycardia that it was likely due to pain and fluid status. And the one of the good example from the model accurately captured it by mentioning that it is likely related to pain and possible dehydration. However, there were also instances where the important information in the goal note, such as no evidence for DVT, was not captured in the predicted note. We also saw an instance where model predicted something in the note that was irrelevant to patient information. So while the actual note contained that information about the resolution of septic shock and the patient was off pressors, the the model still recommended increasing the dose of the vasopressor support. So this highlights uh, that there's more work that needs to be done in this area, and that you cannot blindly trust these models. Uh, so in this case, in this phase, like the manual analysis is very important of the generated nodes. From this second iteration of work, we saw that since the locally run models uh, cannot incorporate the huge amounts of data, we went ahead and tried to use these larger web-based models, and we tried to use them in a way that we don't have to send sensitive patient information to their online servers. And uh, using this approach, we were able to distill huge amounts of chart information to a set of clinically relevant labels. And we ultimately use the local models for node generation, thereby accurately uh, taking care of the privacy of patient information. This work was also presented at ACL as part of the private NLP workshop. And so we saw overall that the progress node generation is an important task, and we created a data set which we call as dark PNG. It contains pairs of progress nodes with alongside the structured chart information, and we tried to automatically generate the progress nodes utilizing the structured chart information between these nodes. We introduced two frameworks for automatically generating these nodes, and we looked at various ways of evaluating these automatically predicted nodes. In the future, we would like to incorporate other types of data, as I mentioned, for example, radiology reports. And we explored the simple types of prompts in terms of generating these nodes. So we did not explore complex prompt engineering strategies, for example, chain of thought reasoning. So these are also good avenues for future research. And these large language models are shown to perform well on specific tasks if you tune them for a specific task. And we believe that the dataset that we created can help in tuning these models. So that's part of our future work to see if we can further improve the performance by fine tuning these large language models on the dataset that we created. And of course, this work was wouldn't have been possible without my mentor at NLM, who is Dr. Dina Nebner-Fushman, and it was supported by the intramural research program at the NLM, and I'd love to also acknowledge the support, the computational support from the NIH HPC cluster. And with that, I'd like to conclude, and thanks everyone for your time.
Excellent. Great. Great. Thanks very much, Dr. Soni. This is really, really interesting. And we've got a number of questions in the Q&A, and I might have a few myself. We'll start with, and hopefully everyone's okay with me just reading these. We'll start with GK, which I believe is Dr. George Kim. Hi, George. Um, uh, and he asked, one area of clinician, burden or need, rather than daily progress notes, would be summarization of an inpatient stay, which is in some sense the discharge summary. Have you considered this or studied it?
So yeah, so this is an interesting task. Like, so when you go toward summarizing information on the patient, what we used for summarization was just this structured information. But definitely, if you incorporate more information from the other parts of the record, then you can produce better context for the model to generate the next progress. But I think what Dr. Kim is trying to ask is that uh, is this different task of summarizing notes studied or not, if I understood it correctly. So yes, that's also uh, a good area of that's actually explored area of research where there are various work on improving on automatically generating summary of patient stay. So for example, generating discharge summaries, and I think sometimes generating summarized context for the clinician to look at. So there's a huge body of work that's available on automatically summarizing the clinician, summarizing the patient information in electronic health record. So that's why like that was not the main focus of the work. So we resorted to seeing like how we can go from this huge information that's available in structured data, and can we use this structured chart information to generate the notes. And we can definitely harness the available uh, studies in the summarization uh, area to further improve this. So yeah, but to answer the question briefly, there is a large body of work that's present in automatically summarizing patient data.
I would also think, and Sarvesh, I mean, I'd love your thoughts on this. It seems like this, if we were to use LLMs as, our tool of choice here, or at least one of them, the
Mm-hmm.
context window problem where, right, I mean, I think in your example earlier, in a 24-hour period, there was an average of 1,500 or so
Yeah,
structured data rows. And then we've got all the other clinical text that wasn't utilized necessarily in here.
yeah.
So doing so over, potentially much longer periods and all that, I would think would be pretty challenging to capture all of that. What do you think?
Of course, yeah. So this was, I think, as we realized, this was like the tip of the iceberg thing where we try to see if this is even possible. Uh, and as you incorporate more context, definitely you can expect better responses. One thought is that when you are using your last progress note, uh, we we felt safe to assume that you don't need information before that progress note. I mean, of course, you can use, because like some information that was not relevant until the last progress note was written may become relevant for the next progress note. So that was like there were some assumptions that went into doing this for the purpose of actually doing something, because otherwise you have this like huge amount of information with you, and you don't have the the open source models or like the locally run models that can actually take all this in and produce something that can be used. And yeah, believe me, we tried it. We tried feeding everything, and it was very like, I mean, we couldn't get useful results with feeding everything. But at least with this, uh, you you are you are indeed losing out on some information. So, for example, radiology reports provide useful context, but uh, you can ignore those parts in your manual evaluation when you see something that can only be pulled in from radiology reports. But this was mainly to see if the model is even able to utilize the structured chart data
Right.
or not. Yeah,
Makes
I
sense.
hope that answers, like, to kind of give my thoughts on utilizing more information.
Yeah, yeah, it does. And we've got another number of other questions too. And Arthur has some interesting ideas in the chat I'd like to get to, but kind of go through the Q&A first. So Sam asks, when accounting for patient privacy, does this model consider patient characteristics outside of standard identifiers that may inadvertently identify a patient? So Sam's thinking, for example, like rare diseases with very small populations that could potentially make someone identifiable, people beyond a certain age and things like that.
Yeah, that's an interesting thought, and it's an important consideration to keep in mind. And we did not do any additional. We did not take additional measures to account for this, but I think, yeah, this will be important going forward if we are dealing with populations like these. Then I think we need to, uh, for example, another thing can be like not use very specific problem names and instead like use something which is a broader category where you have more patients. Yeah, I'm not unable to like think of the example right off the bat, but like I'm what I'm proposing to say is that like instead of saying diabetes mellitus 2, you can say diabetes, but like the diabetes mellitus 2 is safe. But I'm just mentioning as an example that you can do something like that when you are using that particular model with the web-based approach.
Ariana asks, are tasks such as interpretation of abbreviations and acronyms part of any future prompt engineering or fine tuning? And I guess I think we could also take a step back and just kind of ask, how does the model handle interpretations of potentially ambiguous abbreviations, things like that?
Yes, that's interesting. So we did not do anything uh, explicitly to tell the model that what these abbreviations or acronyms mean. So we try to let the model figure it out. But for the most part, what we saw from our manual evaluation, that model was somewhat able to understand these abbreviations, partly because I think it's trained on large amounts of data sets. We don't know for sure how much it takes care of the context. So in that particular context, was it able to determine that value of acronym or abbreviation? So yeah, that's something to consider for future work. That's not been taken care of explicitly. Though, yeah, we believe that model took care of it for the most part. But yeah, we didn't have like a separate metric to evaluate how well the model did here.
It's interesting too. I don't know if this may not be necessarily what Ariana was thinking with the question, but it occurs to
Okay.
me that no, I mean I think your answer is great, Sarvesh, but it
Okay.
occurs to me as we're discussing that like
Yeah.
if and just for the kind of audience, my sense is if we give the model kind of abbreviations in context, as Dr. Soni said, these larger models, anecdotally speaking, can generally figure out what the acronym refers to. If
Yeah.
we use structured data, if we simply put, the output of a database row into, we just throw that at the model, structured data
Right.
can be really hard to make sense of without context in the same way that we have in a narrative, right? I mean, Sarvesh, is that your
Yeah.
sense too?
Yeah, that is very important. Yes, that needs to be taken care of. If you have like if the structured data that you have comes in as these acronyms or, for example, IDs, we did take care of that because if you happen to be like if you were like uh, if you were, I don't know, like call it like fortunate enough to look at mimic data, I mean, but like if you were like burdened enough to look at the mimic data then you will see that the tables do not always contain these text rows, like the text values in their labels. They usually use the IDs. So we use the data tables to populate these labels and then use those data labels directly. So that there was a step in between that we took. We didn't pass the IDs directly, otherwise that would have been like complete garbage.
Right. Right.
Yeah.
Um, so moving on, Adrian asks, a lot of important clinical information is contained in medical teams rounding on patients in the ICU or wards, or in the patient or and physician interaction as an ED or clinic, which I assume it means verbal, right? How do you see the integration of ambient EHR, ambient AI in note generation, and your models of integration of structured data?
Um, yeah, what how we envisioned these systems to be incorporated in the real world as was to kind of generate kind of very preliminary drafts of sorts that can be used by clinicians to write their notes. So it's not to, of course, replace clinicians or like generate notes that can be utilized instead of the actual notes to be written. But this is to assist clinicians in writing these notes. So that was the idea where what if you can generate a draft for the patient, for the clinician? And there are studies not necessarily for progress notes, I believe, but there are other parts of the record where people have tried to use AI to generate kind of drafts for clinicians to use, and there are mixed results at the moment. But for the most part, maybe I'm biased, but from what I saw, that people saw improvements. They did use the drafts in carrying out their tasks. So, for example, responding to patients or writing some writing prescriptions or like these the specific use cases that people explored. So yeah, there are studies where people tried the uh, the use cases that we thought of, that like if you can use it as a draft. But from from like additional thoughts where you can use this kind of technology is that you can create a draft, but you can also help by simply identifying, so like what was the change in the interim. So like instead of having the clinician to go through that complete draft, can you just mention like what were the changes from the last time, and then maybe that can help clinician like speed up the process and so on. So like not entirely produce the note, but you can also just produce the changes, for example. So there are some ways to still use the same technology, but like in a way that can be more usable in the workflow. So definitely like more uh, user studies are definitely needed for specific use case of progress notes to see like what clinicians want, and that's also like part of the future work where we can ask clinicians like whether they like this approach, or is there something else that they would like to see when they're writing their next note.
Yeah, and that's a good segue. I think and this might address what both Steve and Arthur, I think, asked. So Steve asked, does any provider have to quote unquote sign off on the generated progress note? And Arthur asks, does the clinician get the opportunity to edit the generated note? And Dr. Soni, I'll let you address this, but I think just to be clear, it sounds like this was kind of exploratory research work as opposed to something operationalized. Is that right?
Yes, of course, definitely exploratory work. Uh, but the aim was not to keep this like set in stone or something that cannot be edited, like use it or lose it kind of. But this is to definitely allow the end users to edit it or use it in any which way. And the reason that we generated the whole notes, because it's easier to evaluate that way. But you can tweak the task. So like instead of generating the whole note, like I mentioned, you can generate uh, like only the relevant parts. So like I mentioned, a lot of the information is usually the same from the last time. So for example, you saw the continue antibiotics was same between the two notes. So like that happens a lot of the times. So if you generate everything for the next note, the clinicians have to spend those like that extra time reading through that note. So I don't know if that may even defeat the purpose of helping the clinician, right? So but this was for exploration purposes to see what if we let the model generate the whole note, how well it will perform. But I completely agree that like if you put this in the real world, operationalize it, and you will uh, and like we will be surprised to see like here like maybe different use cases of exact same model or doing something that's a little bit different, maybe just generating some part of it, for example.
Um, and this Ariana has a brief follow-up. This might not be a question necessarily, but she just notes that she noticed in the examples that the patient had abdominal pain with peritoneal dialysis. I'm not sure if I'm saying that right, but because this was abbreviated as PD, it seemed that the model dropped these details, or they changed PD to activity, which might be a misnomer or a misunderstanding. It was a little difficult to discern. But it's stepping back. I think she says like she'd be a little worried that there might be a potential flag or potential clue of a problem that would be otherwise missed, because the note was automatically generated. And I think this might be echoed in comments in the chat as well. But just editorializing a tiny bit, I think there's also a remote possibility, and that's maybe not so remote in certain cases, right? That the model finds things or points something out that could potentially be missed or not highlighted by provider too. So this may go both ways. I don't want to, pretend, technology solves everything. It certainly does not. I simply mean to point out that, we're human, and especially in a busy place like an ICU where a lot's going on, I think we have to be very careful of assuming what was written was necessarily the absolute gold standard, and nothing could have been missed by the human as well, right? I don't know. I'll stop there. Sarvesh, what do you think?
No, you're spot on. But I've heard that before. Like, yeah, I mean, I explicitly asked before, like, did um, you try to see like if the actual note was correct? And we did not. Like, yeah, we took the actual note to be like the actual thing and the correct thing. But yeah, we can look at it, but that gives you a different perspective. Like if the models were able to identify something that were not present from before. I think there are studies that try to compare, like many studies now that try to compare like AI and physicians and clinicians. And yeah, I mean, we did not resort to do that. So I think that was not the focus. But certainly, yeah, we did not do that. That can be explored.
Yeah. And I think a common theme is this is really hard. I mean, as your work has shown, and this is really, it's hard to evaluate, right? I mean, it's how
Yeah,
to be, it's just such a kind of dense, multimodal, problem in a lot of ways, that assessing the right answer across this huge, amount of text and data it's tricky to do. Um, uh,
right.
this is great. I know we're coming up on time. We have, I think, kind of one question from anonymous attendee who we love to have. And they ask, could these models be run side by side, um, along like a clinician's daily progress note, and have clinicians choose whether to accept the model recommendation or not in real time? And I think this kind of relates somewhat to discussion in the chat about, how would, does this potentially save time or not? And how would we kind of evaluate that the right information is getting into the eventual note and things like that. Um, and they note this could serve as a quality measure, simultaneously helping out in note writing. So, do you have any thoughts or comments on that?
Uh, yeah, of course, like the main um, like the future use case that we had in mind while doing this is to generate something that can help the physicians or the clinicians who are writing the notes in writing their notes. So this can be something like, keeping a draft ready at all times whenever they are ready to write the note, right? So like if they're writing it at 5 p.m., you have all the information incorporated up to 5 p.m. And if they start writing at 6 p.m., you can maybe incorporate those additional information. So yeah, you can have it in a way where the model, like the clinician can choose to use whatever draft they want. And I think some part of it I already mentioned that, yeah, of course, we want the draft to be editable. It's not something that you use the draft as it is, or you just don't use the draft at all, right? So, and there have been numerous studies that uh, uh, that examined like what happens if you give clinicians a draft of something that was generated by AI, and in a majority of them, from what I saw, that the clinicians did use the draft, and the reduction in time and the reduction in burden is somewhat still explored. It's not uh, it's not clear yet, but yeah, those are like part of like interesting like future work to see like how well does this fit in the workflow.
Yeah. Well, this has been really great, Dr. Soni. Thank you so much, and thank you so much for the attendees for so many questions. This has been really really fun to discuss, and really interesting, timely work. So, and thank you again for attending, and we look forward to seeing you again next year. Happy holidays and happy New Year as well.